Good morning, everybody, and thanks so much for joining us. I know other people are joining. We have a lot of folks participating today, and we really appreciate that. Let's go ahead and look at our agenda. We're going to have, after some housekeeping, we're going to have some announcements and a welcome from our CEO, Melissa. And then we'll have a panel presentation from Copa Health. And then we're going to hear from Christy and Keith on some items of note from Health Current. And then we're going to have a 5-minute break. And then I'll do a presentation on alerts. Then we're going to move to our breakout sessions where you can join your peers for some conversation and feedback. And then we're going to have a report out by some of our team members, our account managers on what was talked about in the breakout sessions. We're going to move to our survey, and then we are going to have some closing comments. So for our housekeeping items, everybody is on mute. We will unmute everybody when we move into the breakout rooms. And to preserve bandwidth for the best meeting experience, let's keep your cameras off except during the breakout rooms. During the presentations or announcements, if you have questions, please type those in the chat box. We have quite a robust schedule, and so we have not built in questions and answers during the presentation, but we will address those throughout the meeting in the chat room, so feel free to type away. And then keep in mind, to be eligible for the Starbucks thank you card, please stay in the meeting and then make sure you take the survey at the end. The survey is not going to be available after we close the meeting, so it's important that you are there at the end to get the link and take the survey right away. And then those email or those Starbucks cards will be emailed within the next week or so. So to start us off today, we're going to receive a warm welcome from our CEO, Melissa Cotrice. Melissa, thanks for joining us this morning.
Wonderful. Thank you, Nancy. Happy Friday to everyone. Hope everyone's had a wonderful week and is staying safe and well in our continued evolution during the COVID-19 pandemic. Wanted to spend a few minutes just updating you all on what we've got going on at Health Current and why this session is so important. So we continue to have a lot happening at the HIE. We continue to grow and expand our services. And as you'll see in our newsletter going out later this morning, even related to the topic of alerts, we're hoping to be able to add some new data elements related to COVID-19 vaccines and other data to our alerts going forward. So alerts, being able to receive real-time notices or batch alerts in whatever way makes sense for your organization, is one of the key services we provide here at Health Current. And we've had several user group sessions over the last couple years, but I'm really excited that we can kick off today with some more robust and interactive user group sessions. We've certainly had group discussions and tabletop discussions at our user groups in the past, but this is kicking off a series where we will have these more frequently, and really it will serve as a way to receive your feedback, your input, and hopefully just have discussions with your peers and other organizations like yours so that we can benefit from how our alerts are being both utilized in the community, and you can benefit by learning from others and also learning from us about what we learn as we implement these alerts throughout the healthcare community. So there just are different ways that alerts are used by different organizations. And that's what is going to be covered today, with some samples and then with some group discussions to identify how we can best continue to serve your organization. So as always, we appreciate your participation. We truly appreciate your input and insight and feedback, because that is what drives our continued improvement of our services and the delivery of those services to you. So I'm excited to have the team walk you through and have some presentations by key participants in hopes that it will really generate some exciting discussion and some productive discussion that can really help us moving forward. So that's just a general welcome. Again, We've got great team members here to lead you through the discussion. I'm going to stay on the line as long as I can because I love hearing these conversations as well. And with that, I will turn it back over to Nancy to kick off this great event.
Thanks very much, Melissa. So we'd now like to welcome our presenters from Copa Health. And we're going to have an introduction from their medical director, Dr. Chern. So Dr. Chern, Dr. Franzak, and team, thanks for joining us.
Morning.
Dr. Chern, are you off mute? There you are.
I'm off. Can you hear me? Can you hear me?
You're a little bit low.
How about now? Can you hear me better? No?
That's a little better.
Okay. Okay, so good morning, everyone. Please let me know if you're having a hard time hearing me. Okay. I'm Dr. Chern. I'm Darwin Chern. I'm the Chief Medical Officer of Copa Health, and we're here today to share with you our experience with Health Information Exchange. We participate. We usually participate in activities with the HIE, with health current because they are listening HIE. They get input from providers, and they really make changes and improvements in their services. So this is a worthwhile activity. So we are here to share with you our experience in using the HIE. So I would like to start by saying that the Health Information Exchange, from what I know, was established to improve patient outcomes through the promotion of good quality coordination between providers. At the heart of this coordination is the need for efficient and timely flow of information to and from medical providers. This is made possible through a tool known as admission, discharge, and transfer notifications or alerts. It is the keystone of care coordination, especially between outpatient providers and inpatient caregivers. As the name suggests, this alert involves monitoring of three key events: admission, discharge, and transfer in the hospital system. This notification is done in real time so that you can follow the movements of patients in the hospital from entrance to exit of the hospital door. This results in decreased time spent in looking for your patient, so to speak, because ADTs can provide you specific names of units of the hospital that the patient had contact with. Providers can also have a clue as to the ongoing course of their patients. In other words, you see how the movement of the patient in the hospital, within the hospital, and it's no longer the hospital is no longer a black box where providers from the outpatient would say the patient was admitted in a hospital and that's it. So now with ADTs, you know which units the person is moving to and leaving. However, ADT notifications or alert system is only useful if the people utilizing the system has a clear grasp of the need to identify the right people, the right patients to monitor, and have established rational flow of information and workflow in their own agencies. A system of managing the data from the ADT is only rational if the data flows to the right staff in a timely manner, and there's a clear strategy on how information may be used to improve patient care. I'm lucky to be joined today by our population health staff. led by our director, Dr. Michael Franczak. So please join me in welcoming the population health team of COPA Health as they give us a glimpse of how alerts are utilized in our system of care. Dr. Franczak?
Yeah, okay. So, Dr. Chern, stay on because I want you to, you were key in getting the initial group, wait a
Yes,
minute.
the next line. Yeah.
You were, the next
Yeah,
slide.
remember, in choosing the groups that will be monitored initially, I remember that is very crucial because if we're going to monitor people who are not needing the monitoring, it will be a useless system. But then we have chosen people who are coming in contact with the inpatient or in the hospital, people coming in contact with hospital systems regularly. So for our choice of our initial groups of patients who would be monitored, we chose patients who are with our assertive community treatment team. These are people who are in the intensive care unit of outpatient psychiatry. That's the way I describe it. They are needing of a lot of monitoring and management in the community. And they come in contact with the hospital very frequently. So we thought that that was a great way to utilize this system because now we would be given, number one, we would not miss any situation where a patient gets hospitalized and no one informed us about it. So now, and secondly, we will be able to respond faster to these patients who are getting hospitalized. Another group that we decided to manage using the HIE ADT alerts to the pregnant members because we need to be able to coordinate and respond to their needs in the fastest way we can. And they cannot. They have needs that need to be met, and we cannot really choose what time they decide to get in the hospital. So we want to be informed about them getting hospitalized. And court-ordered treatment patients would be the third group. And I think the reason is obvious that because we are charged with the court to manage these cases as closely as we can and as good well as possible. So we decided to include court-ordered patients in the monitoring. Then the last one is the population health groups, meaning high utilizers or familiar faces in the hospitals. These are people who are, a small portion of our entire population of patients that are utilizing a huge amount of resources. So that we wanted to make sure that we are closely appraised of their utilization of resources in the hospital system. So our population health team would explain how we were able to use HIE in making sure that we have the data that we need at hand to make decisions and to change directions in treatment planning if needed, and also to be able to coordinate with the people who we need to talk to impact on this patient's care. Dr. Franczak?
Yeah. Okay. Next slide, Melissa. Or not Melissa, but Nancy. Yeah, as Dr. Chern just mentioned, this is a national statistic, and it's a little old, but and you probably are experiencing this yourselves, that a small percent of the population is using most of the high cost services. So if you look at this graph, somewhere around the top 10% of the people are using 65% of the annual expenditure. So what we discovered and I'm sure this is repeated in your own organization, like Dr. Churn said, a good percent of your medical spend is based on just a small portion of your population. We've discovered that 4% in COPA Health are using somewhere in the 60% of the cost. So that's why, as Dr. Churn said, we wanted to focus on who are those people and be able to track exactly what's going on with those individuals. Next slide, please. We've developed workflows, and we also have, Dan Hickson from our IT department, who's going to show you, once we get all this data, what we do with it to turn data into intelligence that we can use and make it actionable. So the IT department, Dan Hickson is our connection with Health Current, manages a monthly list that Darwin has just mentioned to you that we send up our panel. Sometimes we add additional panels depending on something we might want to explore. But the notifications come in real time and batch alerts to designated staff who have specific responsibilities to take that information to the clinical team. And in some cases, when it's an admission to a hospital or discharge, there are specific staff that handle that particular interaction with the hospital. Now, in our program, our integrated care program, we have what's called the daily huddle, which is many of you probably have. And the information that comes in through the HIE is shared in the daily huddle saying, Mike Franzak's back in the hospital again. Or because not everybody is going to get information on the movement of all the people we serve. We serve over 9,000 people with a serious mental illness. Next slide, please. So the campus workflow, we have a clinical coordinator and a clinical director and a discharge planning specialist at the campus. So the clinical coordinator gets the information, and that information is particularly useful for scheduling up follow-up appointments to meet our TIP and our HEDIS measures. The clinical director has oversight, and in the back, in the absence of a clinical coordinator on a particular day, takes the charge to make sure this happens. And the discharge planner, once they're notified of a person being hospitalized, within 24 hours, tries to participate with the discharge team in the hospital. Normally, the discharge planner would be going to the hospital. During the pandemic, many hospitals are not allowing us to enter, but we do connect in other ways. We have a very robust telehealth system that we've initiated. Next slide, please. Now we have at each campus, somebody's called the integrated care coordinator, and we have a care manager who you'll hear from Kim and Julie in a bit. They're assigned to the East and West campuses, but the integrated care coordinator is particularly targeted to the high-risk group that we've identified. The high-risk group is refreshed on an ongoing basis based upon utilization. These folks, and you may not call them high risk, we call them familiar faces, are typically high risk, high utilization, high cost. And what we do is we come up with our high risk list for each campus. Right now, we try to keep it around 30 people, but it's a moving group. And the integrated care coordinator, and we'll talk a little bit more about that, completes an assessment of what's going on. The care manager does what we call a functional risk analysis using the data they get from the HIE, using the data they get from any source possible. And sometimes that data source is the MCO care manager, who's assigned to the case and has been very helpful, particularly the Mercy care manager, to give us additional data so we can piece together what's happening with this person. Why do they have to utilize these services? And in some cases, it's definitely inappropriate utilization. And that's fine. Sometimes we're finding it's more social determinant oriented, which is something we need to intervene. So moving to the next slide. The care coordinator, like I said, are responsible for developing specific interventions. We bring together the clinical team and at a monthly meeting and review a number of cases. We go over the case, present the information we've gathered, and try to come out with, I don't know if you're familiar with the Toyota process of solving things, but it's getting to why. We get in, okay, why is this happening? Where's it happening? When's it happening? And then we keep digging deeper until we come up with a hypothesis of why it's happening. And then we try to target an intervention that either makes that response, if it's inappropriate, unnecessary or ineffective. So we're using higher level behavioral analysis principles to do all of this. So moving on to the next slide. I want to have Kim. Now, Kim is a nurse, and Kim comes at it from looking at the HIE and her materials from a nursing perspective. So Julie, on the other hand, is a licensed clinical social worker. And so she comes at it from a little different. So I want Kim to talk about what she finds in the HIE that's useful for her to come up with her analysis of what's going on. So Kim, take it away. Kim's muted, perhaps.
Yes. Oh, hi. Sorry about that. Yes, I was muted. Good morning. Yes, so as Dr. Franzak mentioned, I am an RN, and I work as one of the integrated care managers with Copa Health, and I utilize the HIE on a very frequent basis because it's a very informative database, and I get a lot of information from the database. But it basically depends on whether the member consents to their information being shared. With their information being shared. So, as Dr. Franzak mentioned, we do what's called a functional rinse analysis, and we gather a lot of information from a variety of sources. And so one of the sources that I utilize is called the HIE. And so some of the information that I can retrieve from the HIE is lab. So for example, if I want to go into the database to find out if a member had A1C while they were in the hospital, I can find out that information. Most importantly, I find out what led to the hospitalization. So it'll give me information in terms of the admitting diagnosis, the discharge diagnosis. I can find out the outcomes of the patient. So for example, if I want to find out whether the member left AMA or if they were transferred to another facility, I can find out that information in the HIE. For example, if we're suspecting that a patient is going into the hospital for drug seeking, we could take a look to see what medications were administered to the patient while they were inpatient. We can find out the admission, why they were admitted, when they were discharged, if they were referred to a certain specialist, that information is in there. If the patient was referred to a certain specialist, that information is in there. So once again, it's a really huge informative database, and I use it on a frequent basis.
One of the things that Kim does, by the way, that I get to see her reports is when someone leaves the hospital, continuity of care is extremely important. Kim looks at, okay, all of these referrals were suggested. Did we actually do them? And in a lot of cases, Kim needs to track down, well, nobody followed up on that, or nobody followed up on that, or they didn't follow up on it. So catching the referrals that are requested is an extremely important piece of what we find in the HIE. So the next, Julie is looking at it from more of a social work perspective. So thank you, Kim.
You're welcome.
Can we go to Julie and have her give us her impressions?
Yes, good morning. So my name's Julie Nielsen, and I'm a licensed master social worker and an integrated care manager with COPA Health. So as Kim and Dr. Franzak mentioned, the HIE really plays an important role in the work that we do. It's essential with continuity of care. So I use it frequently, like Kim. I review the HIE for our members that are identified on the high-risk registry due to high utilization and high risk. And I'm often able to take that information back to the clinic staff, to our clinical teams, to help them make sure we have a full scope of the members' needs and make sure that appropriate follow-up is happening. So sometimes from a social work perspective, I'm looking at the nuts and bolts of what Kim is finding too, but maybe sometimes we look at it just from a slightly different lens. I want to know, why did the person admit to the emergency room or the hospital? What are the discharge plans? Very often we can find in the notes from the doctors aspects of social determinants of health. There may be a mention about the person being in need of food or having issues with housing, other social support issues that we may not have known about. I can think of a brief example where a member, every single time he went to the ER, was asking to see the chaplain, asking for rosary beads and a sandwich. So we were able to take that back to the ACT team and discuss with them, how can we try to meet these needs in the community, so he's not searching them out at the ER. So additionally, when I'm looking in the HIE and I'm looking at labs, I'm looking at doctor's notes, I'm looking at diagnoses and medications, I also want to gain an understanding about the cycles and behaviors as they relate to the member's utilization. Sometimes we're able to identify that there's a certain facility that they prefer, a time of day that they go. Sometimes there are drug-seeking behaviors that can influence those ER visits, and a host of other reasons that someone might go to the hospital frequently. We also, like Kim and Dr. Franzak mentioned, want to see what were the recommended specialists, recommended outpatient treatments, because it doesn't always get to the outpatient clinical staff. So we want to make sure if those are recommended that the team is aware and they're able to support the member in getting all of that necessary follow-up and preventing possibly future utilization that could be unnecessary. Again, we also want to know, was the member, were they prescribed new psychotropic medications, new medical medications, possibly were they getting controlled substances, and is there a pattern of that? And also it's helpful for me to know, was the member leaving the hospital AMA? Were they transferred to another facility? Was there a discharge plan or a discharge to the community that we aren't aware of? So there is pretty endless helpful information in the HIE.
Thank you, Julie. I know that and both Kim and Julie are digging in deeply enough into what we get from the HIE and other data sources. And we're finding in many people, we find patterns. And addressing those patterns has been very effective. It's not, of course, nothing is perfect with everyone, but we have done some great work with the clinical teams. Dr. Churn, and he can jump in if he's still on board here, tasked us with doing better clinical formulations, which means that we bring the group of people together and bring in all the data we have and then sit there and brainstorm. Never blamestorming, meaning, well, why the hell didn't we do this or why didn't we do that? But brainstorming like, okay, who knows this person the best? What are the little things that you know about them that we could use to contribute? But under Dr. Churn's leadership, we have found tremendous improvement in the clinical team's ability to do clinical formulations, which are hypotheses, and then lead to treatment that sometimes it works like a charm. Sometimes it takes a lot of work to get it done. Sometimes it was the wrong hypotheses, and we got to go back to, ground zero. But anyway, the PIR alerts speed us in responding and allowing us to get clinical interventions that are more targeted. And we're able also to reduce lengths of stay as we've tracked our population. Moving on to the next slide. So what we find a lot in the HIE is we find comorbidities that we don't find in our own record. We use it to risk stratify. And Dan and his group and our group are working on developing risk stratification so that we more quickly predict people whose trajectory is going in the wrong direction. We also have developed, as Kim and Julie mentioned, a functional risk analysis, which I refer to as tracking digital dust. We all, you buy something on Amazon or you buy something, in another internet store, and suddenly your computer is flooded with things that is, oh, wow, you like this, so you must like this or must like that. And what the, let's just say Amazon is tracking is they're tracking the choices that you make in your purchasing. So the functional risk analysis, every purchase you make, every kind of contact you make, leaves what's called digital dust, meaning it's in there somewhere. You made a choice. Here's a decision you made. So our functional risk analysis is trying to get at, why is the person making a decision to go into the hospital every month? Why do they go to the emergency room 2 times a month? Why? What does the emergency room find out? And often we've been finding with real high utilizers, the emergency room clears them and says, well, we can't find anything. But it's highly expensive. And anyway, then we look at social determinants. We do a social determinant assessment annually, but a lot of the times we're finding, like I think Julie mentioned, that people are going to the hospital because they have housing instability or homelessness. And any one of us in a predicament like that, in sometimes the heat in Arizona in August, to get out of the heat, we would do things that we would, people are going to the hospital to get out of the weather, to get a meal, to get a shower, to get a bed, to get clean clothes. And then they're leaving rapidly, but many of them are using key phrases like, I think I'm going to harm myself. And they know, and when we do a risk analysis, a suicide risk analysis, that's just a key phrase they use to get in because they have no plan, they have no means, and they're continuing to use that behavior. So very quickly we determine, okay, well, we've got here's a housing need. Unfortunately, with a 3,000 person waiting list in Maricopa County for housing, it's really a challenge for teams to get housing rapidly. So we try other alternatives. Anyway, moving to the next slide. So the other thing we get from the HIE and other data sources, we find undiagnosed and untreated chronic medical conditions. I think Kim already went over that. Sometimes, the hospital discovers something that has been missed in the community because often we see with high risk, high utilizers, they haven't seen a PCP in years. So underlying medical conditions get discovered in hospitals. We also find opioid and deceptions, people using hospitals and emergency rooms for those purposes. We have been able to use pharmacy locks for individuals. We find location and proximity. People, that are living a couple blocks from a hospital tend to overuse the hospital for reasons that the hospital can't find anything wrong. Accidentally, in one case, we positioned a person in an apartment next to the hospital. He decided for socialization that he was going to go to the emergency room every day. We also had, this is a classic case we had one individual who was going to emergency rooms every day. And in discovery, it was found out that her husband was dropping her off there because her air conditioner was broke. So we could have addressed the problem more directly and less expensively by fixing the air conditioner. But until we were able to dig in and find the why, we weren't. For some individuals who aren't connected to a PCP in the community, the hospital has become their health home. And that's what they do. We see issues with health literacy. Nationally, people have found that only about 12% have what they considered sufficient health literacy. And particularly during this pandemic, we're seeing a lot of information coming at people, and people with health literacy are afraid to leave their home, afraid to go get tested, afraid to take a vaccine. So we need to work on health literacy. And then the basic social determinants: housing, food, social isolation. We see individuals leaving and going to hospitals and emergency rooms to escape their families when their families are stressful. We see people going there when they're losing their housing or their finances. Right now, in Maricopa County, a studio apartment costs $898. A one-bedroom is $1,900. The average SSI income is $800. So tell me how you live and pay your rent on that. But anyway, moving to the next slide. So what we have is, HIE and all kinds of other data sources give us interesting information. It's up to us to sift through that and make it actionable. So that's a process that we try to use we use care gaps, social determinants, why they're using, and I'm not going to spend too much time on that because we're practically reaching our time limit. So moving on. So again, I said we have to merge our stuff. So we take our data from the HIE, we take our data that discharge and transition planners, care managers are picking up. We get data from the MCO care managers. We got our claims report and population health reports we get from the MCOs. We get additional data from Access and the TIP program. We have a single EMR that we used. So piecing all that data together so that we have the complete picture is an art. And as I've said many times to people, you really don't want to see how we make our sausage, because putting all that data together can be very challenging. And we're merging spreadsheets and progress notes, and that's where our IT department comes in. So if we move to the next slide, how we know we're getting somewhere is our chief medical officer, Dr. Churn, myself, and our IT staff are reviewing the information we're getting, and we're trying to fix it to make sure that we're getting the most useful, actionable data. Next slide, please. I'd like to introduce Dan Hickson, who is in charge of our IT information that we use. And Dan's going to go through exactly after we get all this data and use it, how he tries to make it digestible and useful to the system. So Dan, it's all yours.
Yeah, thanks. My colleagues have told you what COPA does with the HIE and the ADT alerts, and I'm just going to present this short case study that shows how we automated the ADT alert workflow and the benefits we've seen so far. And this was a process last year on this slide. One of our employees would log onto the HIE SFTP site, download the daily batch file, then match the names and the date of births to the files in the file to our members. Once the members are matched, The records were manually separated into separate spreadsheets and sent to the different clinics. This process took her about an hour each day. If she took the day off or got sick, the work wouldn't get done. Maybe it would get done the next day. And, you know, like the name matching is tedious work, and the data wasn't being aggregated anywhere or used for anything but for notifying the clinics. So if you want to, Nancy, if you want to transition, what we did is we automated this workflow. Every morning, rain or shine, our robot wakes up, retrieves the daily ADT file, adds all the records into our database. The names and dates of birth are matched programmatically, and the separate clinic files are generated and distributed. It happens the same time every day, no sick days, no vacation, nobody's burdened with this tedious work. And since we capture the raw data in our database, it enables us to do things we could never do before, like generate pretty charts. So you can, Nancy, next slide. So here's a very simple chart of monthly admits. And that blip in October was from Integro, I think. But anyway, this is like reporting level 1. This is just the raw counts of data by month. Next slide, please. Because we matched the names of the ADT alerts to our members, we're able to report by clinic or location. This chart shows that we've integrated our data with the HIE data. This provides a high-level overview of which locations and teams have members with high ED/hospital usage. Next slide. Here's another example of an integrated chart. Here we have a custom list of several members we want to keep a close eye on and how their ED usage is going. I'm not sure if you notice, but all our high-risk members are superheroes, and Tony Stark really can't stay away from the emergency room. Next slide. So we've observed a lot of benefits from automating this. And Nancy, if you just want to advance the next 4, I'm not going to go point by point. One thing I'll point out that isn't on this slide, and there's one more, Nancy, is that after automating tasks like this or improving performance of tools, I like to recognize the time savings while pointing out that the bigger point isn't just to save time. I believe the time savings is just the tip of the iceberg. The point is to do better. The point is to change our behaviors as workers in healthcare. Change the behavior of the people to whom we are providing services. The employee who used to do this is now being trained in data analysis and project management. She can now start doing more interesting and more fulfilling work as we continue to automate her other repetitive tasks. I think she will be happier in her new role, and I think our systems are starting to enable our care providers to do their jobs better and our executive team to have a better data in order to lead the company better. I'm a big believer in automated systems, and I hope this case study has sparked some ideas for you on how you can use automation to help the humans around you. That's it.
Yeah, thanks, Dan. Nancy, do you, I don't know if we have any time for questions or whether you really want to do questions, but that completes our work. Always a work in progress.
I think part of the take-home message is that the HIE provides a tool that we can use, but whether it will be beneficial for us depends on how we utilize it and how we make practical and common sense workflows or workflows that make sense for our companies and our patients.
Yeah, thank you, Darwin. I think that sums it up.
Yes, thanks so much. That was a great presentation. We appreciate it. What we've instructed folks to do is to write in the chat any questions. I believe there was one question that Dr. Churn answered, and we will have you guys answer them there. So thanks again. That was a really excellent and very robust presentation. So we're going to move now to some health current announcements. So we're going to welcome Christy Dye, our Chief Business Development Officer, and also Keith Parker, our Chief Information Officer. So Christy, I will hand it to you. Can you take yourself off mute, Christy?
She is still muted, Nancy. I don't know if Christine or someone can unmute her.
Yeah.
Christy, are you there?
There we go. Yep, I got it now.
There we
Thank you
go.
very much.
Thanks, Christy. Lost in cyberspace for a second there.
That's all right. That's all right. Well, good morning, everyone, and thank you, Copa Health. That was an excellent presentation. Really enjoyed the automated piece too. That's a nice add-on. So I'm here just to give, Chief Business Development Officer for Health Current. I just wanted to give a couple quick updates on some key projects and activities and services coming from the HIE, and then I'll turn it over to Keith to do the same on the technology side. So the first quick update is an addition to the differential adjusted payment program. For those of you who are deeply involved with the access system, you're aware that every year there's a differential adjusted payment program, or DAP program, that pays incentives to providers for going the extra mile to do something that improves patient outcomes or reduces costs in the care system. This year, Access actually added a second track to the differential adjusted payment program. It went live on April 1st. It concludes April, there's a misprint in that slide. It should say May 14th of 2021, not April, May 14th of 2021. This particular special track of DAP is related to incentivizing providers to get connected with Health Current's social determinants of health closed loop referral system. So it will be a 1% increase on all fee-for-service claims paid between October 1st of 2021 through September 30th of 2022, based on providers registering by May 14th, 2021, to get connected with the closed loop referral system and then completing a couple additional milestones over the course of the next year. We do have one more informational webinar that's scheduled for May 11th, noon to 1 p.m. At that webinar, you'll learn a little bit about the DAP program, including specifics on the requirements and those provider types that are eligible to participate in this special track of the DAP. And we also have Andrew Tarek, who is our program director for social determinants of health and is overseeing the implementation of the SDOH closed loop referral system for Arizona. He'll do a deeper dive into how that particular platform works. You'll have opportunity to answer questions and things like that. Next slide, please. Again, May 14. Other updates on differential adjusted payments. We will be sending out a clarification on what constitutes the required seriously mentally ill data elements. That applies to integrated clinic providers. And next year it will apply to behavioral health outpatient clinics. So we want to make sure that providers know as soon as possible and in advance, preferably, of when their due dates are, their milestone due dates, on exactly what those SMI data elements are that we need to receive into the HIE. Also coming later this year, I believe it's by November 1st, integrated clinics that are participating in the differential adjusted payment program will need to execute a scope of work with Health Current that will develop in collaboration with you on the data quality initiative that they will undertake over the course of the next several years. Finally, just a couple new services coming your way from Health Current. We will soon be releasing admission and discharge alerts for patients admitted and discharged to level 1 psychiatric hospitals. This has been a huge area of demand and continuing requests for several years from our provider community. And so we're really happy to have put a lot of focus on this particular type of alert over the course of the last 6 months to be able to come up with a solution that can make this data available if, of course, the individual has consented to have their information shared within the HIE. It will also be a key part of hospitals being able to comply with the new conditions of participation released by CMS. I believe those go live on either the May 2nd or May 5th. There's 2 federal deadlines in the same first week of May. So we're hoping to be able to produce some useful information on ADT distribution to assist those hospitals with those particular alerts. And then, of course, for those of you in programs like the Investments Program, or probably through a measurement-based or value-based contract you have with your MCOs, many of you will have discharge follow-up measures, seeing a mental health clinician or a psychiatrist within 7 or 30 days post-discharge. It is very helpful to know the day that the person was discharged, so you know when that clock starts. So we're hoping to bring a solution to all of those very soon. Also wanted to announce that our Opiate Treatment Central Registry service will go live June 1st. This is a system that helps OTP providers across Arizona who have to comply with federal requirements around checking to make sure that the patients that they are treating are not simultaneously enrolled in more than one OTP treatment program. So that's a new service starting June 1st. And then just a reminder to folks that we are always open and accepting applications for health current advisory councils. We have 2 current advisory councils, one on the clinical side, one on the data governance side. You can find those applications on our website. Feel free to submit, and we would love to hear from you. Take it away, Keith.
Well, thank you, Christy, and good morning to everybody. And great presentation from COPA. It is always exciting when you put in the automation piece. So Dan, thank you very much for that. I love seeing those or how our system and how our alerts are being used and automated to support better healthcare outcomes. So a quick update. First update I'd like to start with is our HIE 3.0 transition. This is the transition to our new platform. We are live currently with alerts, and I am encouraging everybody that is receiving alerts from Health Current to reach out to your account manager to begin the transition to our new platform or to our HIE 3.0 or our HIE 3.0 platform. And a couple things behind our HIE 3.0 transition. We did this transition in preparation of an API world, FHIR world. These are all new interoperability standards that are coming. CMS's new rule. So we are seeing higher levels of efficiency and stability, even though we're still moving toward what we're hopeful of, a extremely stable environment with uptimes closer to 99+% across the board as we're doing it. So we're very excited about it. We are looking at all services live by July 2021. So big woohoo to our Health Current team and all of our stakeholders. This has been an extremely long path for us to get to a place with lots of items that we identified that rather than making a choice to punt down, we decided to tackle it head on to include psych and patient alerts and some of the other efficiency things that are going. One item to that, with our anticipated go live of all functionality by July 2021, once we are live and we're scaling, we will be setting sunset dates. And those sunset dates are when we're going to turn off that function inside of our old platform. So we will work with all of our participants to make sure that we have staff available to support you in transitioning to the new platform. The reality is we cannot afford to maintain 2 platforms well into the future. So we will be setting a date for that. I anticipate the date will be once everything's live. We understand the stability and what the resource lift is to be able to transition all those, in some cases, thousands of users over to the new platform. The next item I want to go through is our Cs3 support. This C3 support services really are around the CMS conditions of participation, specifically as it relates to the conditions being placed for those facilities to alert when providers, patients are seen at their facilities. We're working with approximately 23 inpatient organizations to provide them with a service that shows how, based on patient panels, their data is being used and distributed throughout our market, throughout our state. It's actually extremely exciting because the feedback we get in being able to use or leverage other aspects of the HIE, i.e. spread. How is that data being used across our healthcare continuum? And not only being used, but being used to be able to support reduction in utilization rates, reduction in readmission rates, 7 and 30-day all-cause readmissions is extremely exciting. So if from an inpatient perspective in those conditions of participation, this is something you would like to participate in or leverage what's already in place as an existing infrastructure to get those alerts out to providers and their care teams, please reach out to your account manager once again. Next slide, please, Nancy. A couple exciting things that we're working on. As everybody knows, SB 1505 was signed by Governor Ducey. There was an emergency clause to it, which means that it went into effect immediately once it was signed by the governor. What this does is this opens up for ADHS to be able to share some of their data with us. And without going into all the specifics of what type of data is, I'd like to start with, we're concentrating on COVID immunizations right now because we see a huge need to be able to get from the source of truth, which is ADHS, those COVID immunizations into an environment where we can learn on them as well as use them in a dashboard. We are actively working with ADHS right now to do that. I would love to give a time frame, but as I'm going to say, all the technologists and the end users know, we don't know all the bumps. But what I will say is this is one of our #1 priorities here at Health Current to make this happen, so we can have some of the other downstream services. So we are actively working on this to get those COVID-19 immunizations in our environment as quickly as possible. As part of that, what we're looking at doing is using our alert infrastructure to be able to alert on those COVID-19. So if we have one of your patients on our panel and they've had the immunization, we can let you, the care team, know that they have been immunized against COVID-19 or they have received that immunization. The other piece that we're working on is we're actively working with another organization on a immunization dashboard specifically around COVID. And the way we're developing this or leveraging what's been developed by another HIE is to get them the data so providers can go in and, based on a patient panel, do a search. So if you have high-risk patients that you want to encourage to get vaccinated, you can drill down and see who has and or who has not been vaccinated and target those individuals that are high risk or help encourage them to be vaccinated as well. So very exciting. How do we leverage the data to be able to use by the care streams or care teams downstream to be able to provide better outcomes across our population? So a lot of exciting things going on. And I believe that is it.
Thanks very much for those announcements. So go ahead.
I was going to say the one couple key takeaways: account manager is the individual into Health Current. So if you have any questions on this that aren't answered in the chat, please feel free to reach out to your account manager. Thank you, Nancy.
Thank you. We're going to have a little presentation now on our alerts. For those of you who are not as familiar with alerts, I wanted to give you a presentation on what we offer and also what's in the pipeline. So we'll begin by reminding you of all the great benefits of using the HIE, and then we'll take a deeper dive into our alerts. And, you know, what's the use of talking about alerts unless we can talk about how they've been successfully applied, not just at COPA, but at other providers. And then we want to introduce you to our educational series for our participants on the optimal use of the HIE for best patient outcomes. So we're very, very excited to say that we have hit the 900 participant mark this week. This slide just shows you the different types of participants that we have. You know, there's many benefits to using the HIE in your practice, and these are just a few. Information in the HIE can greatly enhance information in your medical record by giving a comprehensive view into your patient's care history. And when seeing new patients, you can have their history at your disposal as opposed to waiting on mailed records or faxed records. And data enhances care coordination and reduces redundant testing. The HIE portal is a significant tool for your value-based care initiatives. Population health can be received without the use of expensive software programs or additional EHR modules. Clinical interventions can happen in real time. So technically, what are HIE alerts? HIE alerts are events-driven notifications triggered by admissions, discharges, registrations, and clinical or laboratory results. And their use is determined by your organizational needs. Alerts can be delivered in real time based on an individual patient panel or patient event who is a patient on a panel, or through what we call a dynamic alert based on an individual registration at a facility. Alerts can also be batched together and delivered on your schedule. Patient panels are a main component on alerts. Patient panels are a list of patients you want to be alerted on. They can be all your patients or just segments by population, or perhaps you want to make them by a team member, your clinical coordinator or an RN, or perhaps by provider. So let's take a look at the alerts we offer. Admission, discharge, and transfer, or ADT for short, alerts you when a patient on a panel has gone to the ED or been admitted to an inpatient facility. Again, they can be delivered real time or in batch, or you can choose them to be delivered by a secure email or STFP. For a few EHR systems, they can be delivered directly into your record. As part of our ADT alerts, we offer patient-centered home alerts, which will notify you if a patient on one of your panels has visited an ED or been admitted to an inpatient facility in one of the HIE states. So Health Current is part of the Strategic Health Information Exchange Collaborative, known as SHIC, and this map shows states that are participating. Currently, over 90% of the US population is covered by this collaborative. You know, and this is especially important in a state like ours that has those folks we call snowbirds, you know, that come every year to enjoy our pleasant winters. You know, knowing they were admitted to your practice can assist with coordinating care with one of those out-of-state providers. If you don't currently receive ADT alerts, I just kind of wanted to show you what they look like. This is an actual alert, which I have removed the identifiable information. Another type of alert is the clinical results alert. These are notifications that a lab, radiology, or other type of document, such as a discharge summary, has been posted, again, for a patient on a panel. And the document is attached, or you can receive a notification only that something new has posted. The COVID-19 alerts are a subset of our clinical results alerts, developed especially for our current health emergency. You can set the alert for both positive and negative results, or just positive results. You know, and this gives important clinical information in real time, or you can choose batch alert. With patients anxious to know their results, real-time alerts eliminates having to go search for those alerts every time the patient calls your practice. So you can get back to the patient right away once it's been posted. And again, keep in mind, they have to be on a panel. And that is unless it's part of our dynamic COVID alerts. These are driven not by a patient panel, but are drawn from the HIE when a patient presents for care. So this ensures you have the most up-to-date COVID alerts. So you can draw those alerts as patients arrive. This slide just illustrates an actual clinical result provided through a secure email. So this is what it would look like when you receive it. Again, this is an actual alert. And this is radiology report seen via secure email. And lastly, here is an alert. Yes, sorry. And lastly, here's an alert via secure email with the document attached. So the high level information is given in the email and the details are attached. Our EMS professionals use alerts to tell them when a patient has been discharged from the hospital, which closes the loop on that patient's care. So we're happy that the EMS community can use alerts to benefit patients also. We have some alerts in development. Christy spoke earlier about the psychiatric hospital alerts, and Keith discussed the COVID-19 immunization information. In development, we also have emergency department notification alerts, or what we refer to as EDNA. These are in production with Dignity Health and will be available on a larger scale in HIE 3.0. So hospitals, watch for that later in the year. So again, I'd be remiss not to talk about another alert success. There are many, but here's one. Horizon Health and Wellness use data from alerts to determine high utilizing patients. They applied workflows for those ADT alerts. They provided additional patient education and extended their hours to successfully reduce hospital utilization. In addition, they improved outcomes for their high needs patients and also reduced ED use and redundant testing, all through the use of HIE services. So what do you do with all these alerts? As you saw from COPA, there is an art and a science to managing patient data. We could probably have a day-long in-service on how to do that and still not cover everything. But, I would be neglectful to not at least skim the topic. So obviously you have to start at the beginning. What are you trying to manage or measure? What might, that might be a population, care patterns, conditions, or of course, your value-based measures. And then from there, you have to apply those workflows, who, what, when, where. And then I would suggest applying those workflows company-wide. So if you're in an organization with several locations, have the corporate office develop those and then monitor their use. And make sure you have backup staff to step in seamlessly. And lastly, use that continuous quality improvement. Dr. Franczak had talked about the Toyota way or lean. You don't have to go full-blown Toyota way lean or Six Sigma to be able to use continuous quality improvement in your practice. That will ultimately enhance your performance and patient outcomes. So if you haven't set up alerts or want to add or change the alerts you use, again, contact your account manager. Your account manager is always the first and best step. for anything you need from the HIE. If you don't know your account manager, reach out. We'll let you know who your account manager is. So lastly, as part of a larger plan, we're publishing 3 guides on alerts. These are going to be participant specific, and the first 3 are for hospitals, physical health outpatient, and behavioral health outpatient. These guides will assist with navigating alerts for your specific patient and business needs. These alert guides are part of a larger series of educational materials to assist HIE participants with enhanced use of Health Current's HIE services and products. These are meant to be a guide, does not replace any internal processes you have in place. It's intended to give ideas to ponder to enhance what you're already doing. We'll be adding a section to our website dedicated to this advanced HIE educational series. Once these guides are published, it's going to be in the next couple weeks. We'll notify all of you with a link. Our next publication after this is going to be a comprehensive guide for skilled nursing facilities. And then we're going to go on from there with other comprehensive guides for different specific organizational types. So, once those are posted, check back on a regular basis to see, what we've added or updated. So if you have those questions, please contact your account managers. If you have something specific or you want to know about the educational materials, you can reach out to me, and my email is there. And this whole deck is going to be sent out to the group, so you'll have all these things after. So we hope everybody enjoyed the breakout sessions. We had a great group in physical medicine, PCP, and specialty, and had some good conversations. Thanks to our account managers who were in the rooms, and they were scribing for us, kind of taking notes. And we just kind of wanted to give you a kind of a report out of what happened in each group. And so we are going to start with Karen Danner, one of our account managers. She was with Peter in hospital EMS. Karen, you want to unmute yourself and give a little report out?
Yes. Can you hear me okay?
We can.
Oh, great. We had Valleywise and Dr. Anthony Dunning. I might have pronounced that Dunning, and I'm trying. In the hospital environment, they talked about dynamic alerts, how we utilize the AO1 and AO4 to report back. There was a lot of use to find through this method to further the care of a patient and have that be more global or dynamic. There was some discussion on other ways to utilize the alerts, but it seems that the benefit has been quite big for Valleywise to use the alerts in their process and workflow. We also had Steve Mann of EMS discuss how they were utilizing it, the alerts, and one of the biggest ways they found it to be helpful was during the pandemic, being able to check parameters on people's symptoms and put them, load them up to the system so that they could track COVID positive and negative tests. Some of the feedback that's coming through as well, I think the emergency services are challenged with seeing how the HIE can benefit them, and they do see the patient value, and they're wanting to know how that will benefit the EMS service itself. And there were suggestions made on speaking to particular EMS services because there are some other utilizations that are benefiting those people. So I think that's all I have on that. Peter, if you think there was something else?
No, it was perfect. Yeah, it was a great conversation we had with Dr. Dunnigan and Steve Mann, and yeah, that highlighted everything we talked about. Yeah.
Well, thanks very much. That was great, Karen. We appreciate it. And I just realized that we are, for some reason, the groups were cut short by mistake. So that's why all of a sudden we came back to the full session. So forgive us if anybody was in full mid-sentence or something. So next, we are going to hear from Kathy Davis. She was with me in outpatient physical medicine.
Good morning. It's almost afternoon. So we had a great group, which took a little bit to get everybody talking, but we also had a representative, Vicki from Valleywise, who was very pleased with the integration of the COVID results into their EHR Epic. One of the challenges that we heard from a couple of users is their challenge with being able to keep up with uploading their panels on a regular basis. So looking for using the robot to streamline those processes for them will be a huge help. We had a couple of new folks that haven't onboarded yet, so they were pleased to hear some of the feedback from some of the other organizations. We did discuss part 2 challenges with getting the data in a format so that we can get that launched appropriately. And the users are very excited to see that coming. So Nancy had mentioned that we're working on that diligently. Let's see, that was really about it. I know Nancy's going to be doing some panels. I'll let her speak to that just a little bit more if she wants to go into that just a little in more detail.
Thanks very much for that, Kathy. You were talking about the patient panels and having workflows.
Yeah, the workflows. Yeah.
Yeah, we just talked about the. Sorry, I was not in camera. We just talked about the importance of, again, those workflows for patient panels. That you have to update those panels to be able to get all the information you need. So thanks again, Kathy. So Rachel, you were in IC with Christy Dye. So we'll ask for your report out next.
Thank you, Nancy. Good morning, everybody. So we started off with Rachel Vega explaining how they use different alerts at their practice. So they receive hospital admissions and discharges that are batched daily that they check. And they also have their care managers that have their own patient panels, and they receive alerts and discharges from emergency departments in real time. So depending on what everyone does at their practice, they receive alerts that work for them and go through their workflow. So the biggest value is being able to track patients and really coordinate their behavioral health care with their medical health. And that means that occasionally they will have behavioral health issues that stem from a medical diagnosis, and being able to link those together and to provide health literacy to their patients is a really big deal. We got some really great feedback about what they're hoping to find in alerts. Everybody's looking forward to those psychiatric alerts. We would like to automate the part 2 process. And we also spoke a little bit about utilizing reporting over alerts, especially for lab reports. Utilizing those monthly reports is a lot easier than going through the real-time lab results. And that is pretty much it. Thank you all very much.
Thanks very much, Rachel. We appreciate that. Okay, next we're going to move to Amanda. Amanda and Andrew were in outpatient behavioral health.
Hey, almost afternoon, everybody. Thank you so much. Can you hear me okay? Okay, wonderful. Yeah, okay, just checking. I'm not a quiet person. Of course you can. Let's see. So just a roundabout group of notes that we went over is that we were really excited about the alerts. We love that we can get the additional information we need to fill gaps in providing the best patient care we can. right? That seems to be a favorite. The COVID alerts coming in batch. They love that they can get that every morning, again, to help with additional care. And then also seeing those alerts come through from ED, inpatient, outpatient summaries that have additional information on them that maybe those sites didn't know about to help create a better care plan for their patients. Some of the challenges they're seeing is getting providers to engage. They're saying, some of them are saying that in the beginning it's kind of hard, but as they start seeing the potential and the benefit to utilizing the HIE, more and more providers are getting on board. Another issue would be that instead of alerts coming directly to the EHR, they're just coming via email, and they would prefer to see that come directly into their EHR, so that way they're not having to manually do so much work with informing providers of those alerts. And then, sorry, give me a second, getting all the notes pulled up. It's quite a bit, did a lot of typing. Andrew, did I miss anything?
Just some people were talking about the psych alerts and
Yes.
noted that they were excited about those. And there was just some, we had a little bit of a discussion about, in some instances, when the alerts come through and they go to check in the HIE, some of the documents are not there in a timely manner. And sometimes the diagnosis for why a person is arrived at the ED is not there when they go to check on the HIE. So there was some discussion about that. And Caitlin gave some feedback to reach out to account managers if you're experiencing this issue with certain hospitals, so that we can follow up to see what the issue is. But that's everything that I have.
Thanks, you guys. Appreciate it. Now we're going to move to Micah. He's going to report out on the bed-based group. He and Jamie Pena were in that room. Micah?
Hello, everyone. Happy Friday. Our bed-based breakout session included 8 attendees who are currently participants of the Health Information Exchange. During our breakout session, we had Paula Reese from the Goodman Group inform us how they are currently utilizing the alerts functionality at their organization. Paula was gracious enough to share kind of an overview of the types of alerts that they're using, best practices, lessons learned, and really just positive feedback specific to utilizing the alerts, as well as the Health Information Exchange portal. The other attendees in our breakout session are kind of all in a similar process and in the early stages of the HIE implementation. They're excited to set up the alerts going forward and excited to just go live in the near future. Key lessons that we discussed is making sure that your staff is informed and trained in HIE practices, specifically to the portal and the alerts, making sure your staff are engaged and motivated to use the Health Information Exchange, and then also having the necessary succession planning so that when there's staff turnover or new team members join, they're trained accordingly. That way, the momentum of the Health Information Exchange sustains and your organization has continued to receive the value of the HIE services that we provide. This breakout session was extremely helpful, and it was a great opportunity to connect the bed-based organizations and really just brainstorm and review best practices. As a reminder, any questions or updates, please feel free to reach out to your account manager. We're always happy to assist. Thank you.
That was a great report out. Thanks, Micah.